So I'm going to talk to you about two different things today. I'm going to talk to you about osteoarthritis treatment. I'm a knee surgeon. I do knee arthroscopy, ligament reconstructions. And I was supposed to talk about arthroscopic treatment of arthritis. That's a really quick topic, and luckily we're going to roll that into discussion of treatment of chondral injuries as well. So that's really the most central thing for you all to think about is osteoarthritis is damage to the white shiny cartilage at the end of the bone. That's what I always tell my patients. If you're eating a chicken leg, you tear the meat off the end, the white shiny articular cartilage, that's what wears down when you have arthritis. It's a good way for them to understand it. And that is a generalized process in osteoarthritis, but the subset of osteoarthritis that's a chondral defect is a totally different animal with different treatment options, and your ability to tell which is which should direct your referral. They should see Joel or Mike if they have osteoarthritis and you've tried all the conservative things that Randy talked about. But if it's a chondral injury, then it's more likely to be something that could be dealt with by an arthroscopist or a non-replacement type surgeon. So let's talk a little bit about what the differences are. Osteoarthritis patients are older. They've had a long history of symptoms. Hurt off and on for years, always cracked up and down the stairs, swells when I go on vacation, when I'm more active and I haven't gotten a cortisone shot from Randy. Not an acute onset, so gradual. I don't know what started it. No defined defect on MRI, more gradual wear out with generalized cartilage damage on imaging studies. And the x-rays that Dr. Reeder was just showing, those are the ones when your x-rays will change. So osteoarthritis is a diagnosis that can be made on x-ray. Chondral injuries, in contrast, oftentimes can't. The way I describe a chondral injury to a patient with regards to their x-rays is, it's like the sink on the top of the counter in the exam room. If you put your eye at the level of the counter and you look across, you can't see that there's a sink there because it's a focal divot. That's what a chondral injury is. And so x-rays oftentimes don't show any irregularity if there's a focal chondral defect. So these patients, like Doug said, are normally younger. They normally have a normal knee until they get tackled playing soccer. Their knee hits the dashboard in a car accident or some other traumatic event. And because of that, the surrounding cartilage is normal and is bearing normal amounts of stress and weight so that the x-ray looks normal because the countertop is holding things up around the sink. It's acute onset, and it's focal with sharp defined margins that we want to be vertical if we get to surgical treatment. So why do we think about these differently? Who do we pick to do what, and why do we pick them? So first of all is patient age. The younger you are, the more aggressive you're going to be with non-arthroplasty treatment. If you see a teenager with an articular cartilage problem, there's not an arthroplasty answer for that patient until everything else has been tried. Even up to probably at least in their 30s, you would never want to refer a patient on in their 30s unless they've had at least to try a conservative treatment unless there's been some massive catastrophic failure in their knee. Location lesion is also very important. We know that the patella, the trochlea, and the femoral condyles are good treatment areas for arthroscopic treatment. The tibial plateau is a bad area. Lesion size is very important. We're going to concentrate on that as we go forward talking about chondral defects. The smaller the lesion presents different options than the larger lesions. How long have they been sore? The longer they've been sore, the more likely they are to damage the cartilage around it. So if you see a 35-year-old who's had symptoms for 10 years after their knee struck the dash, they still may have a chondral injury, but in 10 years, that surrounding cartilage around the defect is not as healthy as it was to begin with. So how long have they had symptoms is important. What's the mechanical nature of their problems? If they're only aching and only swelling, that is less of an indication for an arthroscopic procedure than if they come in and they say, my knee catches, my knee locks, I can't move it. I walked down went hiking with my husband. I've had arthritis for a while, but I went hiking with my husband down a hill. All of a sudden, something started locking and catching. Those kind of symptoms get your attention. The onset. Do they recognize exactly when it happened? Was this a direct injury or is it gradual? And is the plain x-ray normal, which is what you'd want if it's a chondral injury? the short answer for knee scopes and arthritis is right there. If you have a patient who has significant knee arthritis, the short answer is they don't need a knee scope. They need some other form of either conservative treatment with injections, strengthening with physical therapy, wedges, viscosupplementation, possibly an osteotomy and arthroplasty, but they don't need an arthroscopy because there's limited opportunities for us to succeed in a situation where the patient just has osteoarthritis. So what are the options with the scope? They're limited because they're poor results. There's chondral abrasions and microfractures. We're going to talk about all these individually. There's an OATS procedure. There's Carticel. There's high tibial osteotomy and knee replacement. So if you have generalized arthritis, really you're down here. Here you see articular cartilage loss like Doug was showing you on MRI. White shiny cartilage here that's grossly thinned. More normal thickness cartilage over here so you can see how much cartilage has been lost, and then there's a matching defect down on the tibia. So this is not an arthroscopically treatable patient. That's someone that you need to refer on. So what can you do? You could wash it out. That really doesn't do any good, so no one does that. You could do a chondroplasty, and in rare situations where there's an acute onset of mechanical symptoms in the face of arthritis and their predominant complaint is catching, locking, and it's acute and it's new, you can go in and take a piece out and change somebody's life. I've had two physicians' wives, very similar patellofemoral x-rays, both that had loose bodies, both that had dramatic relief from removing the loose piece in the face of severe arthritis. So, but you have to pick your patients very carefully. And meniscectomy, we're going to talk about as we go. So chondroplasty is just removing the piece, maybe smoothing the margins, removing the flap that Doug showed you on the MRI where the piece can be loose and catches. And that's best when there's mechanical symptoms. So here you see chondral surface. This would be grade 3 chondromalacia, all irregular, all fibrillated, fairly deep. But you can imagine that that would catch and rub irregularly, and smoothing that could help. It's unpredictable. I think it's best in the patellofemoral joint when there is a very weak quad because they've been favoring it because of the mechanical symptoms. So on rare occasions, we'll go in and smooth the arthritis and then put them in physical therapy and they can get a big benefit. We would never do that, and I think a rule of thumb is you never take someone to surgery for a chondral procedure that is in the face of some arthritis until they've tried conservative treatment first. This scope should never be a first line for this kind of problem. So here's a little different situation. So this is an acute chondral flap. My probe is in full thickness chondral defect at the inferior pole of the patella. So this piece is totally loose. So this is the edge of the trochlea superiorly. So when this person bent their knee, this whole piece would hang up and catch kind of like over the edge of the joint, and they had marked mechanical symptoms, swelling and catching. So that's something that could be treated arthroscopically just by removing the uneven surface. So how about something that we see every day? The first thing I tell you is you have to remember what Doug said about weight-bearing x-rays. Unfortunately, a lot of primary care doctors don't have weight-bearing capabilities in their offices, so we see people fairly regularly that are sent in to us and they say, oh yeah, you have a meniscus tear on MRI, you need to get your knee scoped. And we say, we look at their x-rays, we realize they're non-weight-bearing, we get a weight-bearing x-ray and we say, oh my gosh, you're too arthritic to be benefited even with a meniscal tear because your arthritis is too severe. So you have to pick your patients real carefully and look at that standing weight-bearing x-ray before you start ordering MRIs. So in patients that have meniscal tears and arthritis, you ask them about their onset. Did they have arthritis for years and have an acute change? Twisted, squatted, felt a pop. That's a positive sign that we can help you. Is your radiograph reasonably normal? Less than 50% loss of your joint surface. Do you have mechanical symptoms? Catching, locking, pinching, sharp pain when you twist. Relatively good except for when you do those kinds of activities. That's a good sign. How long has it been going on? We know that less than 6 months duration of symptoms with a meniscal tear and arthritis is a good predictor for improvement. More than 6 months gets a little more difficult. And how old are you? The younger you are, the more likely you are to try to conservative treatments. So when we talk to patients that have a meniscal tear and arthritis, we say there's 4 predictors that we want them to have the majority of before we would operate on them. Acute onset, mechanical symptoms, a reasonably good-looking x-ray, and less than 6 months duration of symptoms. And I'll count them out for the patients and say, you don't have any of these 4, I don't think we should treat your knee with the scope. And if they've got 3 out of 4, pretty good chance. 4 out of 4, you've got a real good shot, even with some arthritis, of making these people better. And the other thing that we always talk about, and it catches us every now and then, I'll grab a chart, I'll walk into the room, and I'll say, how's your right knee? It doesn't look so good. You've got arthritis. And they'll say, no, I'm here for my left knee. And I'm like, So if the less arthritic knee is their knee that they're here to see you about, there's a good chance that that's an arthroscopically treatable problem even before you get the MRI, because you know they tolerate the arthritis in the other knee pretty well, and so there's a good chance that it's something else in the knee that looks better on x-ray. So what do we do with cartilage injuries in the knee? If they're severe, we're over here. We're going to talk about microfracture drilling, OATS procedures, fetal cartilage mix, which we're not going to talk about too much, and ACI. So you can't do any cartilage restoration procedure on a joint that's not healthy. If the joint's particularly malaligned, you need to address that before you do anything else. So there is a role for osteotomy, distal femoral or proximal tibial, to flatten the joint, to even the pressures, and allow for another procedure, a cartilage procedure, to be successful. Unfortunately, cartilage injuries in the knee are fairly common. 38% of scopes have some chondral injury. This is not a great picture, but that's a full thickness chondral defect, like what Doug was showing you, and here it is arthroscopically. Thick cartilage, full thickness defect. So the problem with cartilage injury is it looks just like meniscal tear. You look at it, they're swollen, they're tender, you push on the joint line, they're sore, they may have that positive rotational grind test, that McMurray's test. So really this is an MRI diagnosis for chondral injury. You can feel grinding underneath the kneecap, but that can be generalized arthritis or it could be an acute chondral defect. So really it comes down to an MRI or even a diagnostic arthroscopy, which is one other point that I want to make. It's an everyday occurrence for those of us that scope a lot of knees, that will scope somebody that has a normal MRI or a normal meniscus on MRI, and we get in there and find it's not. So if you have a patient that you're sure they tore their meniscus, especially the lateral meniscus, and the MRI comes back normal, you have to think in the back of your mind that the MRI just didn't see that tear. It's hard not to say missed the tear, but it really isn't a miss. You can go back after surgery when you know the tear is there and you can look and you can't see it. And that's because obviously MRI is a slice test. If I slice over here, I don't see you guys. If I slice over here, I don't. And if the tear is in the middle, that's a tear that you're not going to see. So I think you really have to trust your clinical judgment, your fingers on exam, and the patient. If they say something's wrong, they're swelling, they're having mechanical symptoms, and the MRI is normal, they probably need a diagnostic arthroscopy because something's wrong. So just remember that when you're seeing patients. So, all right, so these things are difficult to treat. It is the future of orthopedics for how we figure out how to make these problems better and go away permanently. Chondroplasty is an option. That's just smoothing like we talked about. Chondroabrasion, drilling, and microfracture. I do microfracture. I don't like the drilling as much because it can generate temperature, and I don't want that temperature in the bone. You can do autologous osteochondral grafting or an OATS procedure. You can do carticel, or you can do large condyle transfer. So Doug went over this, so we won't spend any time on it. 1 is softening, 2 is a little fissuring, 3 is 50% depth with irregular margins, and 4 is bare bone. That's the outer bridge classification, and that's what most orthopedists use to talk about articular cartilage lesions. When we're sitting around like having a beer when everybody else would be talking about football and we're talking about cartilage lesions. So treatment options definitely overlap. The importance of the depth of the lesion is central. The size of the lesion is very important, whether or not there's coexisting arthritis, if there's malalignment, and importantly, preference of the surgeon. You never want to go to a knee arthroscopist and tell them you got to do their total knee. You never want to go to a guy who likes to do hamstring grafts and tell him you have to do bone, tendon, bone, or whatever. So surgeon preference is very, very important. You want the person that you're going to do what they do the best. So you can't discount that. So this is a super important slide. It's a little bit busy, but if you look at the loops here, you've got debridement and lavage, smaller lesions, marrow stimulation, which is microfracture, up to 4 centimeters, osteochondral autograft, that's the OATS, where we move a piece of articular cartilage. They say you can do that up to 4 centimeters. I pretty much limit this to lesions that are less than 13 millimeters because I'm not a big believer in stacking plugs. So if you take a plug, I like to put the plug into a hole that it will fit into without having to stack plugs, because when you stack plugs, what heals in around those is the fibrocartilage that you get from a microfracture. So I feel like if you're going to be kind of hybridizing a plug and a microfracture together, then that doesn't, to me, appeal quite as much as doing something that's more definitive. ACI can be the truly massive lesions from 2 centimeters to 10 centimeters, and I'll show you a 10 centimeter lesion in a little bit. And then the massive full condyle defects are osteochondral condyle allografts. So let's go over this a little bit. So lesion location. Femur, you can do everything. Patella, there's no good evidence for OATS and carticel. I have done carticel, but it involves having to invert the patella, do a total knee style approach. So that's a bigger deal. In the tibia, there's really no good treatment down on the tibia. So what's microfracture? Microfracture is a marrow stimulation procedure where you poke microscopic little holes into the bone marrow and you let out bone marrow cells, pluripotential stem cells, and blood, and they mix and form a patch over a full thickness cartilage defect. The problem with that procedure is that it's fibrocartilage. I've been back on people that I operated on 20 years ago, and I've seen that the defect looks wonderful, and there's been 20 years of successful fill, and you can hardly tell what's going on. I've been back on people at 3 or 4 or 5 years, and it's fallen apart. And that's the main rub on the microfracture, is how long does it last? So here's some pictures about what that can look like, and we'll go through some cases. So it is a stem cell-like procedure. We drill holes, and fibrocartilage fills in the defect. So here's a defect. This is the defect when it's probed. Here it is when the margins are made vertical and stable, and here it is after the holes are placed. Complications are failure of ingrowth, rapid deterioration, and delamination. It's a double-edged sword, but the younger the patient, the better they do with microfracture, but it may not last as long. The younger people have better stem cells, so their stem cells, they heal in with more hyaline cartilage, less fibrocartilage, so the mix of cartilage is much better. So some of my longest term success with microfractures are the ones that make you most nervous, which are the young people, because if they fail, you have to go on and use a different procedure. But in general, microfracture in young people do real well. And then a little bit about the results. We can skip that. We've talked about that. So advantages, it's arthroscopic, it's inexpensive, it's easy to perform. Smaller defects do really well, partly because they fill better and partly because the surrounding cartilage is so good that it supports the joint well. And intermediate and long-term, intermediate term is very good, long-term is more of a question mark. And then you have that weird kind of double-edged sword in the young patient. They tend to do the best, but they're the ones that need to work the longest, so you have to be nervous about that. The disadvantages, it's fibrocartilage, very long recovery. So the way I take care of a microfracture is 6 weeks if it's on the weight-bearing surface of the femur, 6 weeks non-weight-bearing, a week of 2-touch partial weight-bearing, a week of 1 crutch partial weight-bearing, and then off. Every one of those patients gets viscosupplementation to help protect that cartilage as it's healing in. We've been doing that for about 15 years. We definitely feel like that makes a difference in how that microfracture heals in. We gradually progress their intensity of load, because I think over the first 9 months, that cartilage gently cross-links more and more, so that we really don't want the joint to see shear stress for 9 months. So this is a season-ending injury. This is a red shirt injury. This is something that even the professional athletes, we say, you're done for the season and potentially into the next season. And it can degenerate, and then when we talked about the young people. So quick case here. This is a 14-year-old boy with a chondral lesion in his trochlea, in his patella. Here you can see the irregularity. It was almost an OCD lesion, but there wasn't much bone on the back of the lesion, but you see there's definitely stress and irregularity there. Here you see the chondral flap again with a probe in it. We took that out, cleaned the bed, and performed a microfracture. And he's about 4 or 5 years out. I know his family, and he is playing college sports now without any symptoms. He was a freshman in high school when he had this. Another one, 24-year-old professional athlete, ACL surgery 4 years ago, had a recurrent hyperextension injury. You see the hyperextension injury there, and then here's the defect much as Doug showed us. Articular cartilage here, meniscus here, full thickness chondral defect there. There's the lesion at initial inspection arthroscopically. There's the all holes. There are commercially available devices that help you punch the holes. I like to use an ice pick-like tool because you can feel when you hit it with the mallet how hard the bone is. It lets you adjust that more than you can if you just use the punch. So you don't want to violate the subchondral bone plate here. You want to come in just enough, and it's really cool. All my patients get videos of their surgeries, so I always point out in microfractures when the bone marrow cells start to leak out. They're normally yellow, and you can see the bubbles in the arthroscopic fluid. And you say, oh, yeah, did you see that? That's one of your bone marrow cells coming out that's going to help cap over this defect and help it to heal in. So the microfracture is good down here. What do you do when you start to get a little bit bigger? And one of the things is an osteochondral autograft or an OATS procedure. Here's the steps. You work on the defect, you size the defect, you harvest the piece, you create the socket, and then you pack it in. This is obviously one where they packed in multiple plugs, which I don't think is a great option. So here's a graphic representation, a little bit easier to see. So the defect is here. You prepare it. You harvest the matching size plug from an area where your knee is supposed to not, I said that on purpose, supposed to not care if you take it. And then you move it over and plug it in and put it into length. You can do that here, which in my experience is where I've gone. You can do it around the notch. But again, I think that the single plug is the way to go if you're going to do that. So I don't do this very often because of this. Donor site morbidity is definitely an issue. And when people look at you and you say, wait, you're going to create a defect in one place in my knee that's exactly the same with the one you're treating somewhere else, and I'm supposed to think that's a good idea, they kind of takes a little explaining for why that would work. And you have to trust that they're not going to miss the piece from where you take it from. And in my experiences, sometimes they do. So that's why I think that one plug is real important, and you try and take it from as far out of the way as possible. And then you can have overgrowth, and the technical part of making sure that these plugs are totally flush is very important. Full thickness chondral defect, 3 plugs. This patient did have donor site morbidity. This is one of the last patients I did multiple plugs on, but they had an excellent result for where we moved, but they didn't like me because then they hurt from where I took the plugs. The osteochondral allografts, you size them using reamers. You can take the piece out, core the hole exactly the size you need, and plug the piece in. It's good when there's bone loss because you can take bone with it. Definitely better fresh than frozen, and cell viability can be very high. So for very large defects, this is a good option. Results, complications, any foreign tissues, disease transmission, failure of incorporation, those are really very low. And results are long-term pretty darn good in people that are otherwise crippled or looking at an arthroplasty. So for huge, huge lesions, a condyle, fresh frozen condyle, is a reasonable treatment. So now let's go back to ACI. So ACI can be really massive lesions, and it's a very good option. So what is that? The ACI is autologous chondrocyte implantation or cartilage transplant. It's a procedure we do fairly often where we harvest the cells from your knee at a first surgery, send them to Boston, they're cultured in a culture medium, and then sent back to you for a second stage reimplantation. We now use a synthetic patch. We no longer use a periosteal patch, so that's eliminated some of the complications. And the great thing about this is you get more hyaline-like cartilage than you get if you do a microfracture. So when you biopsy that cartilage later, it's more like your cartilage that you had before you injured it. So this is the steps in how they grow it. Lars Peterson is actually a friend of mine. He's a wonderful Norwegian guy, looks kind of elfish, not very tall, little pudgy, white beard. He's actually been to our center and operated with me doing these procedures. And is really, really a nice guy. So he's kind of invented this procedure in the 1980s. So what do? You harvest a little piece of cartilage. I usually do it from the edge of the notch. You put it in a culture medium. You send it to Boston. There's 2 tic-tac size pieces that you need to send them. And then they culture it and send it back. Then you come back for a second surgery. You clean up the defect, measure it, size it. Now you don't have to make that second incision and harvest the periosteum. You can use a patch that you can size. You sew the whole patch in. Taking each one of these stitches takes a little while. There's 6 stitches, and you're sewing into articular cartilage, so it's pretty meticulous, pretty fine work, and not my favorite procedure because of that. To put in this many stitches is probably about 45 minutes just to put in 15, 20 stitches. With the glue that we have now, the fibrin glue, you don't have to put this many stitches in. I probably would put in for a lesion that's say 2-3 centimeters, I probably would put in half this many stitches and then fibrin glue it and not have any issues with that. So, but still technically demanding procedure. So then once you sew all the areas and you leave a little window at the top, which would be, I've never done this, but truly a bummer to close the top of the window and not have the way to put the cells back in. But there's stories about surgeons that forget to do that and then they have to go lift it back up and put it in. But so leave your little spot in, squirt the cells in at the top, seal the top, and then allow the cells to mature. So it's a very good procedure. The results are excellent. Complications, when we were using the periosteal patch, were hypertrophic periosteal overgrowth. It can get loose, or you can have fibrocartilage that plugs in. Here's kind of an extreme example of hypertrophy of the patch, which caused mechanical symptoms in and of itself. Peterson's now reported 25-year history of maintenance of good or excellent results in a high proportions of people. So it is really a wonderful option, though it is 2 stages in a big surgery. So the advantage is it's more hyaline cartilage. Long-term results are excellent. It can be used in large defects, even in defects that are uncontained, because you can sew the patch to the synovium at the edge of the joint, and young patients should benefit the most. But it's the hardest thing to convince a parent when they look you in the face and you say, microfracture is probably going to do great for you, but it won't last as long. Or you can have 2 surgeries, bigger, more expensive, more risk, real incision, but it's going to last you better over time. It's a really tough thing, and we try to educate the patients and let them choose. Now, there's also the option where you do a microfracture and they fail, and you come back and do ACI. The problem with that is the results are probably not quite as good. So if you really, really in your heart feel like the patient's treatment should be an ACI, you probably should not microfracture them as a first stage. Disadvantages, there's an open procedure for the second part. Rehab is long. The cells to come back are about $30,000. So insurance normally fights with you quite a bit about getting these done. Patch issues are now largely resolved. The long procedure part is why I'm not so crazy about it, and it is technically demanding to sew 6 little tiny stitches into the articular cartilage. For anybody that knows me, I'm not the most patient guy in the world, and for me to put loops on, which is what I do to sew this, is not something I thought I was signing up for when I went into sports medicine. The case that I promised you, 26-year-old professional athlete, failed microfracture for a massive chondral defect. It was basically his entire lateral femoral condyle. It was almost 12 square centimeters, so huge. I don't have pictures of that guy, but this is a representation of it. Here we are measuring the size of the lesion, much smaller lesion. This was about 1.5 by 3 centimeters. There's the patch sewn in, and we're gluing, that's that procedure. So as far as the future goes, we're really trying to figure out ways that we can work ourselves out of a job. The thing that would make Mike the happiest, Joel the happiest, is if we could invent an articular cartilage procedure so that no one ever needs a knee replacement again. That day is coming, probably not in our old guys' careers, but some of you in the audience that are young will probably be treating patients when arthroplasty is a thing of the past. So how is that going to happen? That's going to happen through stem cells, growth factors, scaffolds, and biologic ingrowth. There's a lot of research that's starting in those areas. They're going to take the realm of open surgery and make it more arthroscopic. A good example of that is the open procedure for autologous chondrocyte implantation, ACI. There's now a MACI that's going on in Europe, and that's a matrix ACI. And the matrix is a sponge that you cut to size, you can arthroscopically place it, and squirt the cells in it. So that there is relatively soon, they keep telling us every year that it's coming, there will soon be an arthroscopic treatment for cartilage transplant that involves the ACI cells. So at some point in our lives, knee replacements will be something that our parents and grandparents had, but the patients themselves won't need. Thank you very much.